Matching Adjusted Indirect Comparison, or MAIC, is a data comparison method that can be used when a network of connected clinical trial data is not available. Guidance for this method was released in 2016 by NICE, in collaboration with the Universities of Sheffield, York, and Leicester. Why use MAIC? Randomized controlled trials, RCTs, are the gold standard in establishing how well a drug works compared to another intervention, and the methodology of choice for indirect treatment comparison is network meta-analysis, NMA, using the data from a network of connected RCTs. But what if we do not have a connected network of clinical trial data? We could then look at the option of conducting a MAIC. Using MAIC to compare treatments in the absence of a connected RCT network is known as an unanchored MAIC. To conduct a comparison, we need to be sure that certain variables have been balanced to match the comparator trial. These variables are prognostic factors, attributes known to affect the medical outcomes seen in patients, and effect modifiers, attributes known to make a treatment more or less effective. What is the matching adjustment process? MAIC compares the results of our study with a comparator study. This comparator study would come from the evidence base identified in a systematic literature review, using the PICOS criteria. In the absence of a network, the unanchored MAIC weights individual patient data, IPD, from our in-house trial to mimic the population studied in the comparator trial. This means that observations from subjects with higher weightings will have greater influence on the overall calculated results than those with lower weightings. It's a similar approach to propensity score weighting, in which the individual patient data from the sponsored trial is analyzed and weighted against the IPD from the comparator study. But if IPDs from the comparator study are not available, MAIC applies weightings to patients based on the average baseline characteristics of the comparator studies, which are in the form of published aggregate data. Higher weighting is given to those subjects whose IPD for prognostic factors and effect modifiers is closer to the comparator's baseline attributes, and those who are unlikely to have been included in the comparator study are given a lower weighting than those who closely match the baseline attributes in the comparator study. The weightings are calculated so that the baseline average characteristics are matched between the in-house and comparator studies. Once these prognostic factors and effect modifiers are matched between the two studies, comparisons can be made on reported outcomes such as overall survival, progression-free survival, overall response rate, and any other endpoints where definitions are similar between trials. MAIC can also be used when a network is available, but effect modifiers are not balanced across the trials concerned. We call this application the anchored MAIC approach, where treatments are connected by a common comparator. Limitations. The approaches are not without their limitations. It is important to note that an anchored MAIC assumes that all prognostic factors and effect modifiers have matched, which cannot be guaranteed. Similarly, anchored MAIC assumes that all effect modifiers have been adjusted for. The MAIC can only match the population of the comparator trial. This may not be the target population of the decision problem. It requires there to be sufficient sample size and overlap in the prognostic factors and effect modifiers for observed populations, and assumes that all of these covariates were included in the matching. When to use MAIC? When payers, HTA bodies, clinicians, or other medical decision makers want to assess how treatments compare to one another, this decision tree can help to decide how to generate the evidence for the indirect treatment comparison. If there is no network of head-to-head trial data, we may consider an unanchored MAIC. If there is a network of RCTs, but presenting imbalances in terms of effect modifiers, we may consider an anchored MAIC. If a RCT network is available and effect modifiers are balanced across the network, NMA should always be the method of choice for indirect treatment comparison. Summary. Matching Adjusted Indirect Comparison is a means to indirectly compare two interventions when a network of connected RCTs is unavailable, or a method to handle unbalanced networks.